Thanks, Dr. Goldenberg. So, this morning I'll be talking about the role of metastasectomy in advanced GU malignancies. So, historically, metastatic disease for solid organ cancers was treated with systemic therapy. However, because of an increased understanding of tumor biology and the natural history of disease, there's been an integration of systemic therapies and more aggressive surgery for curative treatment. Early studies with metastatic germ cell tumors have shown that resection of residual disease following chemotherapy has prolonged survival and can achieve cure in a subset of patients. So the integration of surgical resection and systemic therapy has also led to incure rates in other cancers such as Wilms tumor, osteosarcoma, and it is, as I said, well studied in germ cell tumor and also more recently in renal cell carcinoma as well. However, the role in other GU malignancies is less clear. And this has fostered increased collaboration across surgical subspecialties, thoracic surgery, neurosurgery, as well as medical oncology and radiation oncology. So the objectives of this talk are to review the role of metastasectomy in common GU malignancies. And so I've decided to talk about RCC, urothelial cell carcinoma, and prostate adenocarcinoma as well. And we'll also discuss prognostic variables associated with improved outcomes for patients undergoing metastasectomy. So we'll start with renal cell carcinoma. 1/3 of patients with RCC have metastatic disease at the time of diagnosis, and systemic Mets do have a worse prognosis. 5-year overall survival has been quoted between 5 and 30%, with a 1-year survival of less than 50%. Motzer's group identified prognostic factors including performance status, number and sites of metastases, anemia, hypercalcemia, elevated ALK-Phos or LDH, sarcomatoid histology, and then visceral versus pulmonary only Mets. So the sites of metastatic disease for RCC in the order of decreasing frequency are lung, bones, brain, liver and pancreas, the retroperitoneum. So the role of metastasectomy for synchronous and metachronous Mets is well documented in the literature, as I said, especially for pulmonary metastatic disease. In a number of series, they've accumulated over 400 patients who had metastasectomy, and they found an overall survival of 30 to 50% versus 3 to 11% for patients without resection of Mets. So one of the largest series is from Memorial Sloan Kettering, and they retrospectively analyzed 278 patients who underwent metastasectomy for RCC, and all of these patients had metachronous disease. So the majority had lung Mets, and 141 of these patients had what was defined as a curative metastasectomy, so no evidence of disease either on imaging postoperatively and negative resection margins. And this was associated with a 44% 5-year overall survival, which is significantly longer than patients that had a non-curative resection or patients that were treated not surgically. So they performed a multivariate analysis to identify prognostic features which were associated with prolonged survival. And they found that a disease-free interval longer than 12 months, a solitary site of metastatic disease, and a younger age, less than 60, was associated with prolonged survival, and this was significant. Of these patients that had metastasectomy, 94 had a solitary site of metastatic disease, and they found that the lung had a more favorable prognosis than brain. Interestingly, they also found that survival rates after curative resection for patients that had a second and third metastasectomy were not different for patients that had a single metastasectomy. So another group from Memorial Sloan Kettering published a risk stratification tool for patients with disease recurrence or metachronous metastatic disease after nephrectomy. And this was based on Motzer's criteria from 2004. So this was disease-free interval less than 12 months, serum hemoglobin, serum calcium, Karnofsky performance status score, and serum LDH. So these patients were risk stratified and given a score. 0 points was a favorable risk, and 1 to 2 was intermediate risk, and 3 to 5 was poor risk. And so they looked at 118 patients with a median survival time of 21 months from the time of recurrence. And the objective of the study was to see if these risk classification score had anything to do with prognosis. And they did find that overall survival was strongly associated with the specific risk group categories. So the median survival for low-risk disease was 76 months, intermediate risk 25 months, and high risk was 6 months. So in this study, there was a subset of patients that had metastasectomy, and typically these were patients with a solitary site of metastatic disease that was amenable to resection, and the patient had a good enough performance status and would tolerate the surgery. They also found that patients that were offered metastasectomy typically had a lower risk score and that were therefore more likely to have surgery. So 49% of patients that had surgery were low-risk disease. However, in their final analysis, they did not include any of these patients that had metastasectomy. However, they did see a survival difference in this subset of patients, and they thought that this may represent a selection bias because these patients were of such low-risk disease and low-risk monster criteria. And so they were interested to see if this was certainly the case or if having metastasectomy led to increased survival. So they ended up performing a subsequent analysis on another subset of patients to see if the impact of metastasectomy increased survival and was an independent risk factor for improved prognosis. So they looked at 129 patients with metachronous metastatic disease after radical or partial nephrectomy. 80% of these patients had clear cell histology, and the median time from nephrectomy to recurrence was 16 months. And the majority of these patients had their recurrence within 5 years. Again, they stratified these patients based on Monster's criteria. And again, patients were generally offered metastasectomy if they had a solitary site of disease, amenable to complete resection, and were in good enough medical condition to have surgery. And again, this was a subjective assessment by the physicians in the study. Again, there was no information regarding systemic therapy, and it was not included in this series. So 44 patients ended up having metastasectomy, and it was curative intent in about 91%. 4 of the patients had metastasectomy for palliative disease. So the majority of the patients had recurrence in the lung, and most of the patients were at least Karnofsky performance status of greater than 80%, so pretty good. And of the patients having metastasectomy, the majority had lung mets resected. So this is the overall survival curves for all patients, and there was a significant improvement in survival for patients that had favorable risk disease compared to intermediate risk and poor risk disease. This is a subset of patients that had no metastasectomy, and again, favorable risk disease had a significant survival advantage compared to intermediate and poor risk disease. For patients that did have metastasectomy, again, there was a survival advantage for favorable risk disease. And if you look at all the groups together, patients that had favorable risk and metastasectomy had a significant survival advantage over patients that had favorable risk and no metastasectomy. And also patients that were of intermediate risk and had a metastasectomy had a survival advantage if you look at 5-year overall survival. So they found that favorable risk patients, as in their other study, were more likely to have a metastasectomy, and the difference was significant compared to intermediate and low or high-risk disease. They performed a multivariate analysis, and they found that metastasectomy status and also being in the high-risk category led to increased chance of death from metastatic renal cell carcinoma. So, like I said, they were interested to see if having a metastasectomy had a significant improvement in overall survival, or if there again was selection bias based on risk group. So they calculated this interaction coefficient between the two groups. So they said an interaction between two groups exists, between two variables exists if one variable is dependent on the other variable, and if there's a significance between these two, then they are dependent. So they calculated that the interaction coefficient was not significant, and they concluded that there was no evidence that metastasectomy is of benefit only in patients with a particular risk category. And so they said it was an independent factor associated with favorable prognosis. So the conclusions from Memorial Sloan Kettering, selective patients with metachronous mets can undergo curative resection and have a prolonged survival. The following factors were independently associated with improved prognosis, and this was a single site of metastatic disease, a disease-free interval longer than 12 months, a young age, less than 60, lung mets only, and complete resection versus incomplete resection. So they also talked about their monster criteria, and this was a meaningful risk stratification tool, and it was validated in 2 studies. They also concluded that metastasectomy was an independent prognostic factor regardless of risk score. However, survival benefit was seen in patients with favorable and intermediate risk criteria, also who had solitary pulmonary mets and underwent metastasectomy. However, a further study with a larger cohort of patients in a prospective fashion is needed with standardized treatment algorithms. And again, there was no information about systemic therapies in any of these series with regards to details and timing. Sorry? Yeah. Yeah. So another group from Vienna stratified 99 patients, again based on Monster's criteria, to determine prognostic factors as well for patients with metastatic RCC. Now, in this series, patients did have outpatient cytokine therapy, interferon alpha and IL-2 as well for 2 weeks. And again, they performed a multivariate analysis to identify prognostic factors associated with survival. And they found that nuclear grade, so Furman grade, metastasectomy status, elevated CRP and LDH, again, were all independent prognostic factors for survival. So the difference in this study is that the majority of patients had synchronous METs. Again, 85% had clear cell histology, and the majority of sites of disease were, again, the lung. However, patients that had metastasectomy, the majority of patients actually had surgery for bone METs rather than lung METs. And again, in this study, the goal for metastasectomy wasn't curative as it was in the Memorial Sloan Kettering study, but it was more for pain control and pathologic fractures or to decrease intracranial pressure. Curative resection was only in 30%, and only 21% actually did have a curative surgery with no evidence of disease. So 80% of patients that had metastasectomy had residual tumor burden after the surgery. And again, the majority of the patients in this study were of good Karnofsky performance status. So interestingly, in this study as well, the majority of patients in the metastasectomy group were of high risk as compared to the Memorial Sloan Kettering study. And there were a higher number, or smaller number of high-risk patients in the non-metastasectomy group. However, at baseline, there was no other significant difference between the two groups of patients. So survival curves for metastasectomy versus no metastasectomy, again, there was a survival advantage, 27.2 versus 20.6 months for patients undergoing metastasectomy. And again, their multivariate analysis showed that grade, CRP, metastasectomy, and elevated LDH were all independent prognostic factors associated with improved survival. As part of their multivariate analysis, they found no statistically significant difference for survival with disease-free interval, number of metastatic sites, sex, age, stage, or histologic subtype. So they found, like in the Memorial Sloan Kettering trial, that there was a significant difference between the risk groups between low, medium, and high risk. Only 10% of patients, again, were disease-free at the end of their metastasectomy, and there was a high number of patients with higher risk disease in the metastasectomy group, which is the opposite of the Memorial Sloan Kettering trial. And again, in this study, the indication for surgery was more for palliative and curative reasons for pathologic fractures rather than for curative intent. So they concluded that, again, metastasectomy was an independent prognostic factor for patients with metastatic RCC. And they also felt that this was associated with increased survival despite the fact that the resection wasn't curative, which is contrary to the other studies. They felt that debulking of the tumor may lead to decreased acute phase reactants and then lower progression of disease. So they also found, like I said, that this was an independent prognostic factor, and they also found that the survival varied across subgroups. This brings to attention the possible role of metastasectomy for patients with osseous METs and solitary METs with good performance status. So another group from the Cleveland Clinic looked at 417 patients with pulmonary METs. All these patients had a nephrectomy, and 92 of these patients went on to have a pulmonary metastasectomy. Again, criteria for metastasectomy was largely subjective, but as patients with good performance status, acceptable pulmonary reserve preoperatively, and again, younger age, mean it was 60. So the majority of these patients had solitary pulmonary nodules, but there was a good percentage that had more than 5 pulmonary nodules. Majority of these patients had wedge resection of their disease. So, like I said, 50% had 1 to 2 nodules, but 37% actually had more than 5 nodules. 16% of patients in this study had a synchronous presentation, and 12% had disease at other sites. Again, 29 patients received immunotherapy, but they were very heterogeneous regimes, and so again, this was not factored into their subgroup analysis, and these patients were all lumped in together. So of the patients that had metastasectomy, 68% had a complete resection of their disease, and again, this was verified by imaging and pathology postoperatively. So baseline characteristics of these patients, the age was again, median age was 60. All patients had a good pulmonary status preoperatively, and the disease-free interval from time of nephrectomy to time of metastatic disease was about 3 months. The largest nodule median was 15 millimeters. So again, they performed a multivariate analysis to identify risk factors for mortality, and they found that their overall survival for all patients was 89% for 1 year and 31% for 5 years. So the strongest predictor of survival in this study as well was completeness of resection. And they compared patients that had an incomplete resection to patients that had complete resection, and the overall 5-year survival was 42 versus 8% for incompletely resected patients. So here are the survival curves for complete versus incomplete resected patients. And they also found that the chance of incomplete resection was significantly associated with the number of pulmonary nodules on CT. So patients that had more than 6 nodules had a 60% chance of having an incomplete resection, whereas if you had less than 3, it was a 20% chance. They also found that preoperative renal function was a factor for incomplete resection as well, but they thought that this had more to do with debility and other comorbid conditions affecting survival. So again, here's the curve. As you can see, higher number of pulmonary nodules, you have a higher chance of having incomplete resection. So they analyzed the patients in 2 separate groups. One group, the complete resection group, and then they analyzed all the patients together to identify prognostic risk factors. And these are hazard ratios. So basically, larger pulmonary nodules and a higher BUN and a shorter disease-free interval were all associated with higher chance of death in patients with complete resection. When you look at all patients were analyzed together, again, having a larger pulmonary nodule greater than 30 millimeters, or a higher number of lymph nodes, so more than 2 lymph nodes positive, and these are intraparenchymal and mediastinal lymph nodes, and also having a lower preoperative pulmonary function and a shorter disease-free interval were associated with a higher chance of death. However, again, the shorter disease-free interval was only a significant prognostic factor for patients with complete resection, and it was not for all patients. So again, they generated curves looking at the size of the nodule and 5-year overall survival, as well as preoperative pulmonary function. Complications were low in this study. There was no perioperative mortality, and only 9 patients, or 10%, experienced 12 complications. So again, they concluded that incomplete resection was the strongest risk factor for decreased survival. They also found that disease-free interval was only important for patients with complete resection, and patients that had residual disease or incomplete resection, this was a more important factor to do with survival. Again, preoperative pulmonary function was important as well for predicting survival, as well as lymph node burden, so mediastinal nodes or intraparenchymal nodes. Again, they looked at immunotherapy regimens, and they were not associated with increased survival in the study. But gender, age, and tumor stage and number of nodules were not independently associated with higher mortality. But like I said before, higher number of nodules led to a higher chance of incomplete resection. So another group from Germany found similar results to the Cleveland Clinic group. And they looked at 105 patients that had thoracotomy, again for curative metastasectomy for pulmonary nodules. And again, the purpose was to determine prognostic factors in survival for patients undergoing metastasectomy. So 105 patients had 150 procedures, 118 wedge resections, and that was the majority of the surgeries. So most patients had a single pulmonary met, but there were a group of patients that had more than one. Adjuvant treatment was given to 42% of patients, and it was a combination of radiation and chemotherapy, but again, the details were not included in the study. So they performed a univariate analysis to identify prognostic variables associated with increased survival, and they found that, again, completeness of resection, size of pulmonary nodule, and node status were significant. They performed a multivariate analysis as well, and again, they found that the completeness of resection, lymph node status at the time of initial surgery. So these are regional lymph nodes at the time of nephrectomy, not mediastinal or pulmonary nodes. And also the size of Mets were significant prognostic factors. So again, there was a significant difference in survival for patients that had complete resection versus incomplete resection, and no patient in the incomplete resection group lived past 29 months, whereas 62% of patients in the complete resection group did. Again, probability of survival after complete resection, and this is according to involvement of regional lymph nodes at the time of nephrectomy. And again, there's a significant difference in survival. So nodes at the time of nephrectomy is a significant prognostic factor for subsequent metastasectomy. And again, decreased survival with patients with nodes, with Mets larger than 3 centimeters, and this is significant as well. So conclusions from these two studies looking at pulmonary-only Mets, complete resection seems to be the most important factor in increased survival, and this is influenced by the number of nodules on preoperative CT. Also, the size of nodule is also an independent prognostic factor and associated with worse prognosis for nodules greater than 3 centimeters. Also, the status of lymph nodes, either mediastinal, intraparenchymal, or regional lymph nodes at the time of nephrectomy, are also independent prognostic factors as well. So to summarize, for metastasectomy and renal cell carcinoma, there is a survival benefit for a select group of patients with metastatic RCC. However, the evidence is limited to a number of retrospective series with small patient numbers, the largest being from Memorial Sloan Kettering. They calculated the overall survival rate to be 44% as compared to 11% for non-surgical patients, and this was significant. So again, there was a significant survival benefit for patients with favorable risk disease by Monsters criteria, younger age, good Karnofsky performance status, and good preoperative pulmonary function for patients having pulmonary metastasectomy. Again, metachronous metastatic disease was more favorable than synchronous disease, and firm and nuclear grade was also an independent prognostic variable. Somebody's raising a hand here. What does that mean? Was that you? Oh, okay. The majority of the patients in this study are of clear cell variant as well. And positive lymph nodes, either mediastinal, intraparenchymal, or regional lymph nodes, has a significant impact on survival. Finally, the ability to completely resect the tumor burden is clearly an important factor as well. With regards to tumor location, the largest amount of literature exists for lung Mets, and over 600 patients have been amassed in the literature. They do have a favorable prognosis over brain Mets. And again, favorable prognosis for lung metastases includes the ability to completely resect the tumor, no intraparenchymal and mediastinal lymph nodes, size of the tumor, again, less than 3 centimeters, and preoperative pulmonary function is also important in these patients. And the complication rate was felt to be acceptable, 6 to 12%, with a very low perioperative mortality. With regards to bone Mets, the one study talked about incomplete and complete resection of bone Mets for pathologic fractures or palliation, and this was felt to be beneficial for pain control and quality of life. From that study, there also may be a small survival benefit seen for a select group of patients with solitary bony Mets and good performance status. A study from 1997 performed by orthopedic surgeons, and they found that favorable prognostic features for patients with bony Mets in RCC was disease in the extremities versus the spine, metachronous Mets with a long disease-free interval, and also the ability to perform a wide resection and completely resect the bony Met, which is in contrary to the study I presented before. With regards to brain Mets, this is a poor prognosis, and radiation therapy in the past has been highly ineffective as RCC is relatively radio insensitive. However, there is a growing body of evidence for the use of stereotactic radiosurgery, for example, gamma knife. However, the data is limited, but accumulating. So with regards to metastasectomy and RCC, I think prospective, well-powered randomized studies are definitely required to truly determine if surgery has a therapeutic value or if selection bias has played a role in these series. The integration of systemic therapies also needs to be studied as well, as these studies did not include these details to a large degree. And finally, the influence of histologic subtype is largely unknown, as the majority of the patients in this study had clear cell disease, and this was not included in the analysis. So now we'll switch gears and talk about urothelial carcinoma. So the data for this is scarce, and the role of metastasectomy for this is less well known as compared to renal cell carcinoma or germ cell malignancy. Chemotherapy is the mainstay of treatment for patients with metastatic disease, and there are a few small retrospective series with a few number of patients. Early studies looked at patients that were treated with neoadjuvant chemotherapy, and only a small percentage of these went on to metastasectomy. And in the end, the numbers in these studies were too small to make any definitive conclusions about prognostic features or discern if there's any survival advantage. So there's a group at MD Anderson, and they studied 31 patients with metastatic urothelial carcinoma who underwent metastasectomy for visceral and distant lymph node disease. And in this study, it was mostly mets to the retroperitoneum. So they had 22 patients who were initially treated with chemotherapy, cisplatin-based chemotherapy, and then there was also 9 patients that had surgery first, and of 4 of these, they had adjuvant cisplatin and chemotherapy. Again, patients that were selected for metastasectomy typically had the solitary site of metastatic disease, and the tumor was felt to be completely resectable. In the end, 30 of the 31 patients had negative resection margins, either by imaging, postoperatively, and negative margins on pathology. So again, the majority of these patients had chemotherapy first, and then they had surgery, and the majority of them had the non-papillary histology. Now Dr. So's face is on my slides. So the majority of the patients in this study, the resected site was the lung, and then the retroperitoneum as well. Interestingly, a large proportion of patients went on to have a second and third procedure after their initial metastasectomy, even though the majority of them had complete resection at their initial surgery. So median survival at the time from diagnosis of metastatic disease was 31 months, from initial diagnosis, and median survival from time of resection of mets was 23 months, with a 5-year overall survival of 33%. And this was compared to 13 months median survival for a contemporary series of patients treated with chemotherapy alone. So again, survival curve shows a median survival of 23 months. So the limitations of this study, again, it's a small sample size. The majority of patients had a recurrence after their initial metastasectomy, 28 of 31, and there was a high subset of patients that went on to a second and third surgery, and the median time to recurrence was 7 months. They found no survival difference for patients receiving neoadjuvant chemotherapy, but again, I think the sample size was much too small to definitively conclude this. And again, they found no survival difference for patients with solitary metastatic disease versus multiple metastatic disease. So there was a group from Germany, and they performed a prospective phase 2 trial, again looking at metastasectomy in patients with urothelial cell carcinoma. And 70 patients were initially treated with cisplatin-based therapy, and they had chemo-refractory metastatic disease, which itself is a very poor prognosis. So they wanted to look at the effect of survival and also the impact of quality of life on patients that had metastasectomy. So again, patients were stratified according to symptomatic versus asymptomatic metastatic disease. So the majority of these patients had lymph nodes in the retroperitoneum, and the majority of these patients also had a solitary site of metastatic disease, but had multiple mets. Most of the symptoms that patients had were pain, but also lymphedema and ascites as well. So median survival for this group was seven months, which is quite poor. 1 and 2 year overall survival was 30.7 and 19.3%, and perioperative mortality was 4%. So they looked at quality of life as well for patients with metastatic disease, and they assessed this by the WHO performance score. And they actually found there was an improved performance status, which was significant for patients which were symptomatic versus patients which were asymptomatic. And in fact, patients that were asymptomatic and had a metastasectomy had a reduced sense of well-being and a lower WH score postoperatively. So they thought that their poor survival rates were likely due to the unfavorable prognosis of their patient population, specifically patients with chemo-refractory disease. However, 83% of symptomatic patients did have an improvement in their quality of life. However, again, patients that were asymptomatic had no improvement in quality of life and actually had decreased well-being postoperatively. So another group from Japan looked at 48 patients with metastatic urothelial carcinoma, and they were again initially treated with cisplatin-based chemotherapy. 12 patients in this study underwent metastasectomy with curative intent. Again, the patients selected for surgery had good performance status, a solitary site with few mets, and good response to chemotherapy. However, there was no strict prospective criteria to use for this patient selection, and again, it was highly subjective. So in this study, again, the majority of patients had lymph nodes in the retroperitoneum, and then the lung was the next most common site. And like I said, only 12 had resection of their disease. So these are the surgical details of the 12 patients that had metastasectomy. Interestingly, there was viable cancer remaining in all 7 patients that had lung mets after their metastasectomy. 2 out of 3 patients had remaining cancer who underwent retroperitoneal lymph node dissection, and 1 patient had recurrent disease after resection of local recurrence. So in total, 10 patients had residual disease after their initial metastasectomy, and 6 of these had further chemotherapy, and 5 of these patients went on to have repeat metastasectomy. So they performed a univariate and multivariate analysis to again try to identify prognostic factors associated with metastasectomy and urothelial carcinoma. So on their univariate analysis, they found that sex, male sex, white blood cell count, the total number of chemotherapy cycles, so more than 5 versus less than 5, liver or bone mets, local recurrence, incomplete resection, and no metastasectomy were all associated with adverse prognosis. So again, the results of their multivariate analysis, greater than 5 courses of chemotherapy was associated with improved survival. Any liver, bone, or local recurrence was associated with decreased survival, and not having a metastasectomy was also associated with decreased survival. So again, median survival was 42 months for patients who underwent metastasectomy versus 10 months for patients who did not have metastasectomy, and this was significant. So they thought again that there was a possible selection bias, as the majority of patients that underwent metastasectomy had more cycles of chemotherapy and were healthier and did better after surgery. However, again, they did not include the details of performance status in the study. However, they concluded that their median survival was comparable to patients who underwent metastasectomy in other studies. Finally, a group from Germany looked at 44 patients retrospectively who underwent metastasectomy at 15 different centers over Germany. And again, the majority of these patients had metastasectomy for curative intent. And they defined metastatic disease as involvement of visceral or lymph nodes outside of the true pelvis. So again, all these patients had a good performance status. And again, chemotherapy regimens were quite heterogeneous and varied per center, so they were not included in the study, at least the specific details. And the majority of patients ended up having an RPLMD. So 5-year overall survival was 27 months from the time of, 27% from the time of metastasectomy. So this study, they did not define prognostic factors to identify patient subgroups because they felt that their sample size was much too small. 7 patients in the study survived for greater than 2 years and had no tumor progression for a median of 63 months. They felt that metastasectomy was well tolerated with no perioperative mortality. So to summarize urothelial carcinoma, the data for this is extremely limited. There's a small amount of retrospective series, and this does not allow for determination of reliable prognostic factors to aid in patient selection. And again, first-line therapy for this disease should be chemotherapy. However, from the small series, metastasectomy may prolong survival in select patients with good performance status, a single metastatic focus in the retroperitoneum, so no liver, bone, or local recurrence. Also, patients with a good response to chemotherapy and completely resectable disease. Also, metastasectomy may also be used to improve quality of life for symptomatic patients and offer palliation. However, again, larger prospective trials are required before definitive conclusions can be made about patients to have improved survival. So finally, I'll talk about prostate cancer, and the role of curative metastasectomy in this disease is not well defined. Metastatic prostate cancer is largely regarded as a systemic disease and not amenable to surgical therapy. Most patients often present with multifocal disease and are effectively treated with available systemic therapies. However, there are a few isolated reports in the literature. One series looked at 38 patients with brain mets, and 9 of these patients were treated with radiation and craniotomy and resection of their metastatic disease. In this very small series, they found that there was a small survival benefit for patients that were treated with surgery versus patients that just had radiation. There was a case report that was published of a 68-year-old patient who had a metastasectomy for an isolated pulmonary met after radical prostatectomy. So his initial PSA was 6.7, and he had T2A disease and Gleason 4+3. Pathologic analysis showed that there was a small area of 4+5 disease, but no capsular invasion, negative margins, negative lymph nodes, and negative seminal vesicles. 3 months later, he did have a PSA recurrence, and he presented with cough and shortness of breath. So he had a chest x-ray which showed an abnormality and went on to have a CT chest, and they found a 1.2 centimeter nodule in his left lower lobe of his lung. So he underwent thoracotomy and wedge resection of this met. The rest of his metastatic workup was negative, and there was no other skeletal mets or any other sites of metastatic disease. And again, the pathology was well differentiated, prostate cancer. Postoperatively, his PSA was undetectable, and he was started on androgen deprivation therapy, but this was stopped due to side effects. And interestingly, his PSA was undetectable for 12 years after this. However, in summary, the role of metastasectomy for prostate cancer is not well defined. Complete surgical eradication of the disease for metastatic disease is not feasible, and this is likely due to a diffuse pattern of metastases and should not be routinely offered to patients at this time. So I'd like to thank Dr. Black for reviewing my slides, and also Dr. Mickelson for doing the resident library session with us, which was very helpful for researching for this presentation. Thanks.